We are now ready for our keynote speaker, who is Dr. Marjorie Jenkins. Dr. Jenkins is the Dean and Professor of Medicine at the University of South Carolina School of Medicine, Greenville. She's also the Chief Academic Officer for Prisma Health Upstate. She has also worked as the Director of Medical and Scientific Initiatives for the FDA Office of Women's Health since 2015, where she provided sex and gender scientific expertise within scientific programs. Dr. Jenkins obtained her medical degree from East Tennessee State University in Johnson City, Tennessee, and holds a degree in chemical engineering and a Master of Education in the health professions. She is a well-recognized expert in women's health and sex and gender-based medicine, and has served in a variety of national roles, including the program chair of the 2015 and 2018 National Sex and Gender Health Professional Education Summits. Dr. Jenkins has served as the Associate Dean of Women's Affairs for Texas Tech Health Sciences Center School of Medicine and Chief Science Officer of the Laura Bush Institute. She has been honored with numerous awards, including the American Medical Women's Association Elizabeth Blackwell Award, the Women's Health Congress Award for Public Policy and Advocacy in Women's Health, and the Cedars-Sinai's Linda Joy Pollan Advancing Women's Heart Health Leadership Award. We are honored to have Dr. Jenkins join us today. She will be speaking on sex-specific risks and outcomes for women with cardiovascular disease. We'll turn it over to Dr. Jenkins.
All right. Well, thank you all for inviting me to be the keynote speaker. I am so sad that we are not in person, as I'm sure we hoped we would be last year. I actually, sex-specific differences in cardiovascular disease is a really broad topic. So I decided that what we would do is discuss about biology or bias, how sex and gender impact women's heart disease. So we're going to take a really quick journey through this topic, and we'll also leave some time for questions. So I have no financial conflicts of interest, just acknowledging that some of the slides were developed when I was at the FDA and with some of my fellows there, and that my comments today are my own and do not represent the FDA or the University of South Carolina. The learning objectives that I selected today are for us to understand the historical influence of federal regulations in regard to research pertaining to women, to recognize the impact of health policy and congressional mandates, specifically the language that we use, to synthesize the current evidence of cardiovascular disease prevention in women, and to delineate between the sex versus gender influences in diagnosis and treatment, and apply that knowledge to point of care. I know that you recognize this as sex is the biological variable, gender is a social construct, and there is a spectrum. Sex is the majority of the time binary. So I'm going to show some infographics a lot throughout this talk because we are remote. And so looking at a bunch of text on the screen isn't as informative sometimes for some of us. So I'm a visual learner. I just brought in these two infographics to show the complexity around heart disease in women, and especially to point out the specific sex-specific issues that we see related to women in relation to pregnancy. And this summary of updated recommendations for primary prevention of cardiovascular disease, it was interesting to note the author actually pointed out that we have not had updated guidelines in relation to prevention of cardiovascular disease in women since 2011. And so they created this. It's quite a good article. So let's talk about history and epidemiology. Our own Dr. Lundberg, I pulled this infographic from a publication of hers, and it really does show the great amount of work that has been done in this space over the past 25, 30 years. Yet the 10 most common causes of death in women out of 4 categories continues to be coronary heart disease. So let's take a quick look at health policy through the sex and gender lens. The FDA policy, I'm going to go quickly because you all, I am sure, know this, but we had a mandate in 77 that women could not participate in early phase trials if they were of childbearing age, even if they chose to do so. The NIH inclusion policy in 1986 had to consider the inclusion of women. And remember, I said to pay close attention to the words we use in health policy. GAO study, we're going to look at 3 GAO studies within NIH over the next few decades. And what you'll see is that the verbiage that's utilized, and I'm showing here in blue, is really important for us to consider. It was applied inconsistently, and it's impossible to determine whether NIH was enforcing its own recommendations. So that was in 90. The GAO typically comes over to FDA after doing an audit of NIH. And we found that in FDA approval processes and pivotal trials that women were underrepresented and the data was not analyzed. And there really weren't, in many cases, numbers equivalent enough to see any differences in efficacy and safety. So this guidance, I want to point out, and I've underlined that guidance at the FDA means encourages. It is not a mandate. Sponsors, pharmaceutical companies really should take the advice of FDA, but they're not required to do so. This guidance in 93 encourages inclusion of women and requires analysis of data on sex differences. And that guidance has not yet been updated, despite being over 25 years old. The Revitalization Act in NIH started the Office of Research in Women's Health. Again, women and minorities were to be included in clinical research and in adequate numbers to ensure data could be analyzed for an effect of gender. And I will tell you, in the federal landscape, they utilize gender incorrectly because we did not get these the 2 definitions until the IOM report later. But really, when you're talking about safety and efficacy, for the most part, you are talking about sex differences or impact. The demographic rule for FDA shows that Congress did provide a mandate to FDA. One second. So we have allergies here in South Carolina. So Congress did provide a mandate to FDA and give FDA the authority to require that sponsors tabulate the pivotal trial data for approval by age, sex, and race, and to analyze safety and efficacy by age group, sex, and race in new drug applications. A new GAO study. I told you we were going to look at 3. So here's the second. NIH lacked protocols to enforce. NIH lacked adequate data tracking. Again, the lack of compliance could significantly impact the ability to apply sex differences in clinical management and outcomes of disease. This is in a $33 billion research environment. So this is also an FDA authority. So FDA can put a hold on an investigational new drug if men or women with reproductive potential are excluded from participation only because of their risk of reproductive or developmental toxicity. To my knowledge, and when I was at FDA, I could not find one clinical hold that actually happened and where FDA had utilized its authority in this space. So what can FDA require? Guidance documents encourage the inclusion of both genders. Regulations require the reporting and analysis of demographic data in NDA applications, but they are not required to be powered to do so, to look at those subgroups. So what it can't require, it cannot require participation for demographic subgroups in clinical trials due to sex-specific drugs and drugs known to behave differently in subgroup like sedative hypnotics in the elderly. So only in the event that there is a known sex difference can they then require adequate numbers. The IOM report showed us in 2010 that we had made progress in cardiovascular disease and others, but very little in maternal morbidity and mortality, autoimmune diseases, addiction, and Alzheimer's. And then in 2015, this is the third GAO report. We have 57% of the NIH-funded clinical trials were women. Does not track. We've seen that twice before over 20 years. Lacks summary data to identify potential sex differences and limits assurance that NIH is supporting research that can inform medical practice for both men and women. We've seen that before. So in 2016, this report by Dr. Clayton and Director Collins actually sort of launched the sex as a biological variable policy within NIH. And here are some of the words around that policy. Consideration of sex may be critical to the interpretation, validation, and generalizability of research. Sex data by sex may therefore enhance. The NIH expects that sex as a biological variable will be factored into research designs, and investigators are strongly encouraged to discuss these issues with NIH program staff. What this does, it lacks the teeth to mandate that this policy be implemented across the NIH centers and institutes. What does this do for us? All of these policies that really don't have mandates or repercussions attached to them if researchers do not follow them, shows us all along these environments that we can insert bias and avoid knowledge around sex and gender differences. And that's why the pipeline of research really to clinical care looks like this: male predominant or unknown in cellular, and all the way through to where you get to healthcare consumers, and 80% of healthcare consumerism per the World Health Organization is consumed by women. So we are 5 years past sex as a biological variable. And this, I pulled a quote from this article. The NIH is engaged in ongoing efforts to develop resources to help investigators consider SABV in their research. So again, I have talked to several leaders of study groups at NIH, and it is variable where they actually require that sex differences be looked at and or they don't fund the particular study. So I just wanted to allay a myth of women's participation in clinical trials. I still read in the literature where women don't want to participate in clinical trials, won't complete clinical trials. There are too many complex variables around women. We all know that these myths have been disproven, but one of the nonprofit Women's Heart Group actually came to the FDA and asked that the FDA pull the data on women in cardiovascular clinical trials. And we see here that women in clinical trials actually we have improved somewhat, but we've also lost ground in the late phase clinical trials. And we know that this is published on the FDA's website, Drug Trial Snapshots, a summary report every year. They look at all the new molecular entities, the new drugs that are approved that year, and women participated in 56% of those clinical trials in 2018. So we are making we've made a lot of headway in women participating in clinical trials, and yet sponsors and others still use the crutch that women won't participate in clinical trials. So we did a 10-year review of all the cardiovascular drugs that were approved in these areas: pulmonary arterial hypertension, and women's participation exceeded disease prevalence. You might actually infer that because that is predominantly a disease of young and middle-aged women. Approach disease prevalence in atrial fibrillation, and below disease prevalence in heart failure, coronary artery disease, and acute coronary syndrome, myocardial infarction. So we also had the ability for 5 of the drugs to look at the screening data. And what we found, and one of the thoughts was that women were disproportionately being excluded due to exclusionary criteria, but screening did not exclude enough patients to account for the differences in participation. Pre-screening factors actually did. We looked at study inclusion and exclusion criteria, and it was very minor, the effect on whether men or women were to be accepted into the trial. So I actually developed this graphic for the manuscript that shows you actually get out what you put in. So there isn't more leakage of women along the pipeline for clinical trials. And so there's an issue here, somewhere here in the pre-screening and referral for screening where we are missing the mark. So now for the rest of my time, until we start to take some questions, I just wanted to take us on a journey through the scientific literature and how it paints the picture of a woman's MI journey. So we have the ABCs of prevention. Many different institutions and others have defined the ABCs of cardiovascular prevention. This one I actually pulled from Johns Hopkins, but I also added another A for awareness of risk. So let's talk about prevention along the ABCs. And what does the literature tell us in regard to women? So 10-year differences in women's awareness related to coronary heart disease, results of a 2019 American Heart Association National Survey. This survey was actually disheartening, very disheartening for us. Actually, it showed that in 2009, there was a 65% overall awareness that women have. Now, remember the Go Red for Heart, the Red Dress campaign started in the early 2000s. And in 2019, we had a 44%, and higher awareness was linked to white women with higher educational attainment, non-Hispanic, Black, Hispanic, and non-Hispanic Asian women were 58, 59, and 67% less likely to identify cardiovascular disease as a leading cause of death. So we continue to marginalize certain populations. We have seen that during the pandemic, and it is pervasive. In 2019, women were more likely to incorrectly identify breast cancer. Having had a mom who passed from breast cancer, I think this disease is very important. But we do lose more women, 4 times more women annually to heart disease. And in 2018, heart disease was a leading cause of death among women, and all cancers ranked as the second leading cause of death. And breast cancers caused 42,000 plus, whereas heart disease was over 300,000. Even more troubling is young women's perceptions of heart disease risk. And I say that because this is where we have the opportunity to intervene and prevent heart disease and events and death later in life. So this was just a semi-structured focus groups of women ages 15 to 24, small group. But here were some quotes. I feel like those are things I associate with older people. They were surprised to actually learn that heart disease was a leading cause of death in women. I usually hear more about men suffering from heart problems. We're so pressured just to grow up and be more focused on pregnancies or depression or our weight as reasons for their low perceived risk for heart disease. We don't have time to worry about hearts, especially if our hearts aren't bothering us to begin with, and we can't see it. So the Lancet did launch a cardiovascular disease commission to reduce the global burden by 2030. We began talking about sex differences in heart disease over 25 years ago, and now we're looking at 2030 to begin reducing the global burden. Somewhere we are missing the mark, and it is complex, and there is no shame or blame here that I'm trying to do, but just to show like where we've been and where we're going. The B, ABCs, blood pressure. The prevalence of hypertension is greater in men. It increases in postmenopausal women, and hypertension in women is more likely to be associated with increased waist circumference and kidney disease. Hypertension in men more likely associated with smoking and dyslipidemia, and women have increased variability in ambulatory monitoring and less likely to have the 10 millimeter or more nocturnal dip in blood pressure. So beyond the 2017 guideline for prevention, detection, evaluation, and management of high blood pressure in adults, we actually found that there are quite a few sex and gender specific factors that were not even acknowledged in the 2017 guidelines. In fact, some colleagues of mine, Dr. Barry Mers and Dr. Wendy Klein, and I wrote a letter to JAMA after publishing those guidelines to really point out that they only mention sex differences in relation to pregnancy. So you can see here, there's prevalence increases after menopause, prevention to maintain normal BMI, physical activity, and also screening, ambulatory blood pressure monitoring, and our therapeutic target. This was out of that Dr. Cho article that I showed the infographic in the beginning of the talk. So women of childbearing age have staggeringly low rates of lipid screening, and OBGYNs may be key to getting more women screened. That's probably correct. Almost 50% of women utilize their OBGYN as their primary care physician. And you may or may not know this, but OBGYN for federal payment is CMS are considered primary care, and they lobbied for that title to increase repayment back in the 90s. For payment for services. So the race and sex differences in the management of hyperlipidemia, I point these out because I really want us to begin thinking about the intersectionality of variables and what creates a perfect storm in certain patients. You can see here, this is a little bit blurry, but just to note that this is the overall prevalence. The white will be white men, then white women, Black men, and then Black women. And you can see some of the awareness, lowest awareness is actually in Black men and Black women here. And these are the Framingham risk scores, which are 20%, greater than 20%, 10 to 20, and less than 10%. So there's decreased awareness among women. And then for treatment also, there are some statistically significant differences in Black men and women here. So again, the Dr. Cho article has some great infographics, and I just bring this here to tell us where the, when should we think about statins for prevention in women, when not to, and what's a maybe and needs a further discussion. I think that in some respects, we overutilize statins. We do know that women are more likely to complain of myalgias and other side effects. And if you're treating a woman with multiple risk factors for cardiovascular disease, also noting that there's been some link to statins and development of diabetes, type 2 diabetes. So I am actually going to, I'm actually going to go to the C, which is cigarette cessation. And cigarette smoking is down, but almost 38 million American adults still smoke. 1 in 4 adults are still utilizing. I am fascinated by the history of cigarette smoking and how it appeals to women. So first was the Lucky brand cigarettes that was for weight loss, to keep slim, to keep a slender figure, no one can deny. And then you've come a long way, baby. We've already seen this and how that made it appear that smoking was more attractive. I don't know how they ever sold that. Smoking rates for women have not declined as quickly as those for men, and we see that here in this infographic. It is well documented, though, that women often have a harder time quitting smoking and do not respond as well to some nicotine replacement therapies compared to men. Women do tend to utilize smoking as more of a social, anxiety reducing, et cetera, compared to our men. And also we know that smoking is a leading preventable cause of women, preventable cause of heart attack in women, and women who smoke are more than twice as likely to, as non-smoking women, to have a heart attack. So how are we doing in primary care in delivering smoking cessation interventions among participants in the National Lung Screening Trial? And this is a great example of how physicians are asking. So here's the light blue, physician visits. This is the physician asked about smoking. Gray, advised. The dark blue, green, assessed. assisted in cessation for the patient, and down here in the gold, actually arranged for an intervention. And you can see that we are pretty abysmal here in as we get into the assist and arrange. But what does that matter? What does the evidence show us? Well, we see that the receipt of ask, advise, and assess was not significantly associated with quitting in multivariate models. Assist was associated with a 40% increase in the odds of quitting, and arrange was associated with a 46% increase in the odds of quitting. When I was at FDA, our Center for Tobacco was going to do a major campaign around vaping and smoking cessation. And they had a message that was tagged to that, one more time, like one more time. And I asked them, had they market tested that with women, because, that tends to be, set in sports and other things, and might be not as appealing to women and encouraging them to try quitting again. And the director actually did not think that was going to be helpful. These are just some questions. These are easy as a primary care physician. I'm an internist, as you may know, and just asking and advising and assessing. The evidence-based literature shows us that we're documenting that in the chart, but we're not really moving past. If a patient is determined to quit smoking or expresses a desire, then we should move over here to assist and arrange and helping the patient quit. We also know that there are sex differences in therapeutics to assist with smoking. The varenicline actually has a 41% more likely to achieve 6-month abstinence in women, 38% more likely to achieve 6-month abstinence in women than bupropion. And for men, these effects were smaller and not statistically significant. So not only as we keep going and thinking about patient care through a sex and gender lens, let's not just stop at the epidemiology and the early stats and screening, but let's move into the therapeutics to see if the literature tells us there is actually a sex difference. And what about diet and weight? This is staggering to look at the prevalence of obesity among adults over 20 by sex and age in the United States, 2017 and 2018 in Haines data. And we also see that here in the gray, we have non-Hispanic Black, the percent obesity. Again, we have really high rates of cardiovascular disease risk factors in this population, and it's excessive in how much obesity we have and other prevalence of risk factors, and yet we are less likely to provide the discussion around diet and exercise related to that. So do the 5 A's work when physicians counsel about weight loss? I don't think I've ever heard more disgruntlement from my colleagues than if they get so discouraged about talking to patients about their weight. And I think that is something we can't give up. I mean, we really need to keep looking at what we can do to help our patients achieve weight loss, to lower their cardiovascular risk, to increase their quality of life. And here we don't have a lot of literature in this space around, do the 5 A's actually assist? But we do have some data from NHANES about healthcare provider counseling for weight management. And you can see here in the red, which is telling them to increase their exercise. And I find that to be really interesting because exercise affects the rate of weight loss, but you will not lose weight if you do not change your diet or caloric intake. And I just find this really interesting that sure, we should walk at least 30 minutes a day, have 150 minutes of exercise during the week. But at the same time, a patient could start doing that, not see any results, and then stop exercising because it's not helping. So we need to also give counseling that's appropriate and understand that exercise only affects the rate of weight loss. So we have apps. to actually help weight loss, Noom. And I will share with you personally, I've used Noom. I lost 30 pounds with Noom, and I really did appreciate it. Very simplistic, but it is a really good app, and it actually has data that's been published in the literature that shows that that the majority of people who use Noom and follow the program actually do lose 10% or more of their body weight. So let's talk about diabetes. We have pre-diabetes, 86 million American adults, more than 1 out of 3 have pre-diabetes, and 9 out of 10 people with pre-diabetes do not know they have it. We have different measurements we can use here. Fasting blood glucose about 15 years ago. Remember, I've been in this space about 20 years, 23 years of sex and gender medicine. And there was some data early or in the early literature about fasting blood glucose. And so I would proceed for an oral glucose tolerance test in my women who were on the cusp, and would more likely than not would be able to push them over into either a concerning range for in their blood sugar, and be able to counsel them, because what we see once we get to diabetes, underneath that is the entire iceberg. It really isn't that tip that we're actually treating. So focusing on disease course and outcomes, there are sex differences, there are gender differences in glucose homeostasis and diabetes. Women have lower fasting plasma glucose. Impaired fasting glucose is more prevalent in men. Type 1 diabetes is the only common autoimmune disease that actually affects men more. Estrogen deficiency or testosterone excess predisposes a woman to type 2 diabetes. When I perform consultations in regards to hormonal imbalance, we do not have any FDA testosterone products for women, but they are used off label quite a bit, especially in some of the cash pay consultants out there that want to really take women who aren't doing well in their menopausal transition and provide them with a lot of testosterone or testosterone pellets. You can actually move women into the type 2 diabetes range by doing that. So and a lot of other things if you give too much testosterone, as well as deficiency predisposes men to type 2 diabetes. So let's talk about the prevalence of physical inactivity among adults in the US as of 2018. And you can see here, one of the, so we have 32.2% in Black, here's Hawaiian, Pacific Islander, Hispanic, much lower in the white population, other race, multiracial. But basically we are not a country that the majority of us actually participate in physical activity most of the days of the week. So comprehensive cardiovascular health promotion for successful prevention of cardiovascular disease. This was published, and this is an editorial and an article that I really think you should try to review. The presentation and diagnosis of MI, this is where science outpaces practice. I know that most of you probably know that physicians, the majority of physicians do not follow even level 1 evidence in our clinical guidelines. And also we have an issue where we still want to practice sometimes the art of medicine. We want to follow our gut. We have anecdotal evidence from previous patient outcomes. And so we're still in that mode, even in 2021. I pulled this infographic instead of going through a lot of literature for you. We all know that heart attack symptoms that are common in women may not be as common in men. We also know that the typical clutching your chest, chest pain type presentation was a middle-aged white male. And that has permeated through the decades, so that when a woman, especially a woman of color, goes into the emergency room system, less likely to be diagnosed, less likely to be screened for an MI or cardiovascular disease, and moves into that realm of anxiety and depression and or GERD. We've made some progress, but we still have not closed the gap of women dying within a year of myocardial infarction, and within 5 years, 50% 50% of women will die after a myocardial infarction, compared to 36% of men. The gender, actually, this is gender of the physician. And I just want to point out that the author here should not have used female and male. That's the sex of the physician. We would not know that unless the physician shared that with us. So whenever we're talking about environmental studies, let's use the correct terminology, which is women and men, woman and man. But we do see that the probability of survival from cardiac treatment in a Florida emergency department showed that the sex of the physician actually did impact the survival from cardiac treatment in relation to a woman physician versus a man physician. There's some data also that shows that if you have women ER physicians that and working with men physicians, then you actually have some of the practice of some of that bias actually decreases in the men physicians. So, and I'm really not trying to make a blanket statement around all women physicians or all male physicians. Just interesting that gender did have an input here. And then I just was looking at the history. First, we had chest pain, and then we had CK and LDH and others that came into the 90s, and troponin was identified in 1990. And then we have now, of course, the high sensitivity troponin. So I recall when I was a resident at the University of Cincinnati, a second-year resident, I heard a cardiologist, Dr. Laura Wexler, actually present some of her research around sex differences in myocardial infarction. That was a really eye-opening experience for me. And I think that's probably why I moved into women's health and internal medicine for sure. And I had high sensitivity troponin discovered. Sex-specific thresholds for high sensitivity troponin gained some utilization, but actually it is not widespread, especially in the US, regarding the high sensitivity troponin levels and that 99th percentile cutoff related to diagnosis, the universal diagnosis of MI, the fourth universal diagnosis of MI that's been adopted. So treatment bias remains, and that results in stagnation of improved outcomes in women. And just to show you what the authors found in this study, where you have implementation of high sensitivity troponin and sex-specific thresholds, while they did diagnose more women with type 2 MI, which is the MI that occurs, or myocardial injury that occurs without the atheroma and plaque rupture, they did find that the treatment, women were less likely to be treated in this study. And this was over 43,000 subjects that they looked at this data. And women were also less likely to receive coronary revascularization. And here are the treatment interventions that they looked at, and you can see that women were less likely to actually have received CABG and all of the other treatments here. And then the bottom is actually had previous treatment. And you can see here that women are also somewhat lower in certain categories related to treatment. So I actually heard about women being less likely to receive preventive treatment like aspirin and statins over a decade ago, probably a little bit more. And I will tell you that it is surprising to me that in 2019, when this study was done, and also today, that we are seeing women not receiving level 1 evidence preventive therapies. So how do we address the gender bias in treatment? Well, we have the opportunity to implement objective protocols. And I'm going to give you an example, a really stark example of how this works. in the Cleveland Clinic. So Cleveland Clinic prides itself on being a global global destination heart center. In the ER, diagnosed STEMI, they looked at the standard of care that men and women receive. They found that women were less likely to receive standard of care by clinical guidelines, and the door to cath time, door to needle time was longer in women, and the 30-day mortality was statistically significant and 6.1% higher in women. So what did they do? They implemented a very simple 4-step protocol that the ER criteria did not require cardiology consult, that they would follow the guideline-based drug therapy, independent of sex or gender, immediate transfer to the cardiac cath lab, and initial radial approach for vascular access. And many of you may know that since the early 2000s, those of us in the sex and gender medicine world were telling cardiologists that the femoral approach for women increased the likelihood of major blood loss. And now, decades later, we actually see that it is a recommended approach. So how did the 4-step protocol impact what was probably implicit gender bias on the part of the practitioner for treatment? You can see before protocol here at the top, all the numbers that we talked to you about here. And then after the protocol, what happened? Every patient actually benefited from implementing the protocol, even men and women. It closed the gap on the statistically significant 30-day mortality. So, but there's still a difference here. And so what did this do? What they did was remove the opportunity for the provider to insert their gender bias and of course, implicit gender bias. As a dean of a medical school and someone who worked for 15 years in the development of curriculum around sex and gender medicine, we do have a sort of a hidden implicit agenda in medical education where we are, by either omission, we are actually not telling students when the evidence has been performed in one sex over the other, or if we really don't know what the actual outcome is across populations. And that is also true for race, ethnicity. And I think that we need to be, if we're teaching evidence-based medicine to our future doctors, we need to acknowledge where the evidence has gaps. So from biology and bias to clinically meaningful. I used to tell people that at a cocktail party, I could talk about anything from hair growth to bunions around sex and gender differences. I read it voraciously and really enjoyed learning about it over time as the evidence increased. But probably a lot of what I actually was going to tell people was not going to be that clinically meaningful in improving the outcome. Now, this was in early 2000s. Actually, it took about probably 15 to 20 years for us to amass a great cache of evidence so that we could apply it in our clinical day-to-day practice. So we have practitioners who aren't as voracious about reading about sex and gender differences. And so we need to give them a digestible and clinically based process and reference to apply meaningful results to point of care. And as I said, the summary of updated recommendations for primary prevention, great article, great publication, enjoyed that. They actually are less likely, they did not mention counseling the patient in relation to all of the recommendations for primary prevention. So I think with all of the technology and point of care access we have, like pocket ultrasound, et cetera, I think we're getting away from what we know actually can benefit a patient, may take more time than writing a prescription for a medication. But definitely we need to be careful that we're not moving too far away from the basics in regarding to preventing cardiovascular disease in women and men. So this is a book that I published, Elsevier published with, and Dr. Connie Newman and Connie's an endocrinologist in New York, at New York Langone, and this was published about a year ago, but it's very case-based. It's very much about point of care. I'm not asking you to purchase this book, so I'm not plugging this book in relation to that, but you can look at some of the chapters online, and I think you'll find it to be very practical, and we give very specific bullets on the point of care. And why I tell you about this reference is because throughout every chapter, you will almost always find in the point of care, the practice points, that physicians should use validated screening tools when assessing a certain disease. I'll give you an example: obstructive sleep apnea. The stop bang is a two question, takes about 30 seconds for a woman to answer that. One is, do you snore? And yet women are consistently underdiagnosed in sleep apnea, very large risk factor for future stroke and cardiovascular disease and renal disease. And yet we are underdiagnosing women, telling them to exercise more, get more sleep. They're depressed. We treat them with a depression. Well, actually, a depression med does not treat, as we know, obstructive sleep apnea. And yet if we just implemented a very quick screening test, we could increase our diagnosis for women related to that. So enough about that. I just want to tell you about our patient's journey. She may have lacked awareness of cardiovascular disease, probably so. And then we have uncontrolled or missed risk factors, may have presented to the ER and been misdiagnosed or diagnosed and undertreated, not given lifestyle counseling, and has years of life loss. So in examining the complexity of cardiovascular disease in women, are we missing the basics of risk reduction? So things to consider. I will not read these to you because you have my slides, and I'll be sending Sharon an updated PDF to distribute to the group. Because I did add a few slides, and just to understand that we are still struggling for women to be aware that cardiovascular disease is the #1 killer. We are not utilizing evidence-based therapies in the basics, and I will put that on my primary care colleagues as well. The intersectionality, though, is markedly important. Sex, gender, race, ethnicity, and age promulgates adverse cardiovascular outcomes in younger non-white women. And our United States Preventive Task Force guidelines, as well as many others, as I talked about, the 2017 hypertension guidelines, fail to acknowledge differences in prevention of heart disease in women unless they are related to pregnancy and or mortality, maternal mortality. And with that, I will take questions, and I thank you for your attention.
Am I up? Okay. There we go. Thank you so much, Dr. Jenkins. That was an incredible talk covering from prevention and some of the challenges with women being enrolled in clinical trials, and also gender bias with delivery of care. I'm going to start with our first question here. I was surprised to see the decline in awareness in 2019 down to 44%. I would have thought that with increase in social media, et cetera, awareness would have increased. Any thoughts on why the decline in awareness over the past 10 years?
You know, I'm not sure that I have an answer for why the decline, except maybe when we were in the early 2000s, we had the Centers of Excellence in Women's Health. We also had the Go Red, the Red Dress campaign. We also had the February Heart Month, and we still do, but every month has a disease process associated with it. October, Pinktober for breast cancer, et cetera. So I think that we have, I think the Komen nonprofit, as well as others, did a great job of telling women about breast cancer. I think it's it's scarier to women to talk about breast cancer. And why are we not talking about it on social media? Well, who's on social media? My 3 adult children, early 20s, they're on social media and they're not talking about heart disease. I can assure you. So what we need to do is we need to engage those young women. We need to engage them in talking about it. You know, when the president brought in one of our social media influencers to encourage vaccination in teenagers and young adults, the COVID vaccines, they listen to their peers. We need to start increasing that. We also need our physicians to remind their patients, pregnancy, postpartum visit, if you've had gestational diabetes, hypertension, preeclampsia, premature delivery, your OB-GYN, your primary care doctor should be asking you about that and reminding you that this portends potentially a heart disease or stroke event later on in life. So that's the best I have there. We need to reinvigorate the campaign around heart disease awareness in women, because it's a tsunami of risk factors. You saw the obesity, you saw the smoking, the pre-diabetes numbers. We really need to all of us need to get really passionate about this again. And we need to get it out there to increase public awareness. Sorry, I am a little passionate about that myself, right?
No, we need this. And, just to piggyback on your comment about pregnancy history, that is something that all of us who care for women patients need to do. At our Center for Heart Disease Prevention, that actually is part of our new patient intake questionnaire. Did you have gestational diabetes? Did you have preeclampsia, pregnancy-induced hypertension, or eclampsia? And that allows us to have the opportunity to have that conversation about the risk of future development of cardiovascular disease. A lot of women don't even know. They know they had eclampsia. They remember they had preeclampsia. They had to deliver early and had a C-section, but they don't know about that connection with cardiovascular disease.
Exactly.
So I wholeheartedly agree with you, but all clinicians who take care of female patients need to start having that discussion with our.
And I failed to mention this, but I want to say it now. You guys have one of the best global heart disease clinics and treatment centers right there at Emory with Dr. Lundberg and Dr. Wenger. And I will tell you that I actually utilized your model when I launched a sex and gender specific cardiovascular disease clinic at Texas Tech. I received a $5 million grant to do that. And we utilized a lot of your protocols because they were so great at looking at the things that people don't think about. You should have seen the women's faces when at 60, I asked them about their pregnancies. They're just like, what? But it's important.
Here, yeah,
Right.
They think no one's asked me that in probably 30 to 40 years, but that makes a difference right now. Absolutely.
Exactly.
All right, so our next question is here. Curious how you would approach prevention or lipid treatment in women of reproductive age. If they want to be pregnant, how would you stop their lipid therapy and when to restart?
Yeah, so that would depend on if the woman had, I think, a history of an actual cardiovascular event. There would be a lot, I think a lot more gravitas to that discussion around stopping her statin had she had a previous event. We also know that women are delaying childbearing. So we have more women of advanced age that are actually starting to have pregnancies. If the woman is first assessing her risk, but we also know that our risk calculators are not thinking of those atypical risks in women. So that's where we as the clinician need to paint the picture for the woman. We need to have dialogue with the patient. The paternalistic approach of I'm going to tell you what to do in medicine is not going to, we don't need that anymore in medicine. We need to talk to our women patients. We also need to tell about the risk versus the benefit. I can tell you that the literature tells us that pregnant women are very averse to taking medications, even if they know that it is needed, like even asthma medications, autoimmune. disease medications, antidepressants. And even if there's good data on that, we don't have a lot of data on statins in relation to pregnancy outcomes, because we continue to protect pregnant women from research instead of protecting them with research. And if you really want to know more about that, there's a congressional task force that was formed in 2018. I represented the commissioner at FDA as his proxy, and I can tell you that we just don't have enough data. You have to have the dialogue with the woman. You have to talk about what her current risk is, what the risk is, what we may know during pregnancy, and then the outcomes. And I think that's where we as physicians tend to probably try to shorten that discussion, but you really can't. I mean, it's complicated. It's complicated. I would just do it on a case-by-case basis. Having as much objective data versus what we think anecdotal evidence that we've had experience in.
Sorry about that. Yeah, no, you're absolutely right. And the thought has always been that when our patients become pregnant, that you stop the statin. But to my understanding, there's a new document coming out in the next few weeks that's going to change the recommendations for statins with women. But typically, of the lipid lowering treatments, none except for Welchol is one that has been prescribed during pregnancy. Now that we have the PCSK9s, it wasn't really studied in that patient population. But for patients who have familial hyperlipidemia, LDL apheresis is one treatment that can be done during pregnancy. So we'll see what the new discussions are that come out in a few weeks.
Well, we were at the table with Big Pharma and this congressional task force, and I can tell you they are very averse to having women, even with women who become pregnant in a trial, are taken out of the trial immediately, instead of given the opportunity to remain and have that sampling done, so we could at least get some pharmacokinetic data. But really, they're just averse and worried about litigation and liability.
Yeah, it's unfortunate because then there's that whole area of information that we don't have at all. All right, the next question is, I was impressed by the results of the 4-step protocol that you shared to address gender bias in STEMI care. I wonder if this should be considered when it comes to a referral for ICDs, recommendations for statin and antihypertensive medications, given the gender biases we see in those areas as well. What are your thoughts?
Please do it, because we have so much hidden gender bias that we are consistently under-treating, under-recognizing, under-diagnosing, under-treating women across the board. When you look at the prevalence of disease and the number of procedures that women actually receive, when there's evidence-based, they meet the guidelines. CRT, for example, the FDA itself combined four pivotal trials data to get enough women to actually look to see that CRT was underutilized and that it led to increased risk of death in women. And that was published about, I think, in 2015. But here's the deal. We have the ability to do this, but societally, I think just thousands of years, we have sort of a protectionism around women, or some type of misperception that women won't want a procedure. And we need to move that out of the way and implement objective guidelines. I'd love to see more literature like the Cleveland Clinic study. You could do it there. We could do it here at University of South Carolina at Prisma Health. And in fact, I actually wrote down some research questions as I was doing this keynote to take over, because I'm the chief academic officer at Prisma in the upstate. So, but yes, please do objective guidelines and please measure your outcomes and publish them. We need more.
Absolutely. Many women, especially minority women, do not know how to gain access to healthcare specifics to women's health. Do you have any suggestions?
Could you repeat the question?
Yes, many women, especially minority women, do not know how to gain access to healthcare specific to women's health. Do you have any suggestions?
Well, I think first physicians need to understand that women are internet surfing for answers. And so we, as in my women's health practice in Texas, I always had a list of reputable sites where women could get good data and good information. So you should be sharing that with your patients. However, it goes farther than that. We know that minority women and men actually assess better quality of care and better compliance and ask more questions if the physician looks like them or has shared life experiences. And yet we have only a handful of Black African American and Hispanic Latinx students entering medical schools per year. We're talking about 12,000 that actually come into the pipeline in medical schools. So we don't have the physician population and practitioner population, APPs, that I believe are able to really think about these things in relation to our minority populations. And so I would start with the physician's office, but I also think we need a public health, public awareness campaign of where can you get good data. It's not in the chat rooms or the blogs where people always write about the worst case scenario. We really need women to have the access. And we know that, women of color are just as likely to use their cell phone to get their health information than to use any other method. So we really need to really study that and be able to leverage that.
Absolutely. Our next question is, do you have any data in gender bias concerning non-traditional and or non-binary genders?
Oh, goodness. Oh, so I will tell you that we have, when I was at FDA, one of the major areas that I worked on was the utilization of sex versus gender terminology. And in fact, with isotretinoin for acne, the I Pledge card actually made it impossible for a trans man to get isotretinoin because they would have to say that they were a woman of childbearing age if they had not gone through medical transition. And when I looked more closely at the 500 pages of documentation that they give to physicians who prescribe that, they talked about heterosexual sex. They talked about, it was very traditional. And it was very inappropriate. So we did work that, but it's pervasive in that space, that binary language. And I used to think we didn't have a lot of information around sex differences back in early 2000s. It is so much worse in our non-binary populations. And in fact, NIH, it's actually, I had the director of the sex and gender science office that was organized about a decade ago come to the FDA. And she actually did a study of where we were funding research in that population. And what she found was that it was around HIV, STDs, and domestic violence. And yet our trans men and trans women are given high dose hormones for life, and not one FDA approval for transgender health in the hormone status, not one in the FDA. And how does that impact their cognitive function? How does that impact their heart, their bone health? We do not know. And that is a huge gap that needs to be closed. And we need NIH to lead the way.
Yeah, we definitely need to do better with that. And I know we're just a few minutes over, but this is a very important question that I wanted to have you answer and leave us with your response. You talked about the gender differences when it comes to enrollment in clinical trials. What can we actively do as clinicians, both from an organizational level and from an individual clinician patient level, to improve participation of women in clinical trials?
So thank you for that question. I will say that we have a macro environment and a micro environment when it comes to clinical trials and starting clinical trials. The sponsor may not require you to try to reach a certain percentage in your study, but you should seek the percentage of women in your study at least to equal the prevalence of disease, which in heart which when coronary artery disease or coronary heart disease is typically more like 50-50. So we really need to strive for that. What we tend to do in clinical trials is we need to look at, number one, a feasibility checklist. Can we get that patient population in this clinical trial at our site? Number two, we need to, as the PI, tell our clinical trial staff, these are the numbers we want in related to enrolling patients in this trial. What happens is we get to the end or near the end of a clinical trial and we go, oh, we don't have enough diversity. We need to start enrolling more diverse patients. That you're far past the window of being able to really impact that clinical trial. Number two is we need to lobby FDA as well to enforce the power and authority they have. Sponsors almost always come to FDA to talk about the clinical trial before they start the protocol, the clinical trial protocol. And yet FDA doesn't counsel them or encourage them to reach some type of prevalence of diversity in their clinical trial. So there's that macro environment, your organization. How about going to your IRB? And how about your IRB actually coming back and saying, hey, you don't have any thoughts about enrolling women in this trial, and yet we know the disease is 50-50. So we've got IRBs, we've got the federal landscape, as I told you, that isn't helping us in that space. We have clinical trial teams who are very successful, Emory, top notch, but we're not thinking about diversity at first. We don't think about the public awareness, or when we're advertising for clinical trials, we don't think about even the visuals of that marketing campaign. We're not going out into those communities and getting those people that are the sort of the hubs where the leaders of the communities, which might be your pastor. And so we need to get out there and talk about community-based participatory engagement. There's a lot, and I know I'm saying a lot of different things, but I actually created a national training on increasing diversity in clinical trials while at FDA. And we gave very practical steps and very practical resources. And I'm happy to send that those slides as well to you, but there's a whole pathway from beginning to end to actually get diversity in clinical trials. Big pharma is not going to do it if the FDA doesn't make them, and FDA doesn't have the authority if Congress doesn't give it to them. And then we get into what can we control as the PI, and you can ask yourself those questions on the ground, but also ask your colleagues those questions when you see clinical trials that are ongoing. Ask them, how are you going to engage a diverse population? I want to tell you, I know you guys hear a lot of data from me, but I will tell you that there is a bias in enrolling in clinical trials, and I'm going to give you just food for thought around that. We also had a study where we looked at the point of care data for pivotal trials over 2 years at FDA. And what we found was that, that patients of color had 25% enrollment in schizophrenia trials, but only 2% in cancer trials for the same years. Now you tell me that we are not dealing with huge bias. So you have to be objective about your approach and to take away that bias, but also call it out when you see it.
Absolutely. I will definitely take you up on that offer to share your training when it comes to the slides you mentioned about increasing minority enrollments in trials. I think that as a researcher myself and many of our attendees, and we work with other people who are involved in clinical trials, it starts with us. And so we need to train ourselves, and then we can train others. And that's when we start to see the change. So thank you for sharing that, and also for highlighting the most recent recommendations for prevention of cardiovascular disease in women. That is a very timely read. And we have some of our Emory Women's Heart Center team members who are on that, who co-wrote those guidelines, Dr. Pooja Mehta and Dr. Viola Vaccarino. So I think we have all the information is out there. We just need to take advantage of those resources.
Well, you guys have rock stars there at Emory. You have a phenomenal heart center. So kudos to you.
Thank you so much for being our keynote speaker. While we're sorry that you couldn't be here physically, we understand the landscape of what's going on right now. And I get the feeling that having listened to this talk and your Q&A, that the impact is no less virtual than it would have been in person. So thank you so much on
Thank you
behalf
very
of our
much.
team and our attendees.
Thank you all. Bye-bye.